I do wonder if Tim is here, though. Perhaps he's late. Anyway, welcome everybody to the joint Kensington and Chelsea and Westminster Health and Wellbeing Board of the 27th of May 2021. As is the case with our meetings, I'd like to highlight that the last meeting was hosted by Westminster, and so I propose that we lead the discussion from Kensington and Chelsea for this concurrent board meeting. And therefore, as the RVKC chair, I'd like to ask the RVKC board if they approve of my proposal. And I'll take silence as a given. In the absence of Councillor Mitchell, I believe then the vice chair would be Councillor Barnes. Would you be able to ask if the Westminster board are happy with the proposal as well?
Sorry, Cam, I'm just coming online. Give it 1 sec. There we go. Taking a sec for my camera to turn on. Very happy to do that. Didn't know that was my role today, but pleased to do so. Westminster colleagues, does anybody have any objections, or can we otherwise take that?
No, fine.
Oh, thank you very much. Appreciate the vocal expression, Councillor. There we go. Thank you, Chair.
Perfect. So, as both the boards have approval, I'll now be the chair for this meeting going forward. As you may be aware, the advice around council meetings has changed. Any meeting that could now go ahead in public should go ahead if it is decision making. As no formal decisions are being made at this time, the meeting can be virtual, as it is today. And as COVID restrictions remain in place and that no formal meetings are being made, we're holding this meeting on Microsoft Teams with all the participants joining remotely. The event is also being streamed live on YouTube, and members of the public and the media are welcome to remotely follow the meeting and listen to the discussions therein. Committee papers for this meeting are available on our websites and via the calendar invite. And due to the size of the Health and Wellbeing Board, and to ensure that the virtual meeting can run as smoothly as possible, only official board members, those presenting papers, and anyone who has requested a speaking slot can participate in this meeting. Everyone else should be able to view the meeting via the public live streaming. Any questions from the public are submitted in advance to ensure public accountability. And then, as we are all now used to such things, but I will run through them once again. As this is a Teams live meeting, could everyone please remember to keep their microphone muted unless they're invited to speak? And likewise, to improve bandwidth, could people please turn off their videos if they're not speaking? And then if I lose internet connection at any point during this meeting, Councillor Mitchell should be stepping in as the substitute chair. I'm afraid I'm not entirely sure who steps in if he's not there. So perhaps I could delegate Councillor Barnes that responsibility, but hopefully my internet in the Kensington Town Hall will hold out. And then if any participants wish to speak during the meeting, please use the chat function in the top right corner, and I'll keep monitoring that. And then separately, we should note that there's been a change of the agenda order, and that the Royal Brompton update will be taking as item 6 instead of item 8, as I believe they have to leave early. Thank you. Good. Okay, so moving on, we have item 2, which is apologies for absence, and apologies have been received officially. Sorry, I'm hearing myself on an iPad in the back in the room. And apologies have been received, and I believe they can be noted without me having to read them all out directly. Therefore, we can move on to item 3, which is declarations of interest, and to ask if any of the board members or officers have any interest they wish to declare in respect of any of the items to be discussed. And again, I'll take silence to be consent. And then I'm going to ask if there's any other matters arising with declarations of interest at all. Again, nothing. Lovely. So we're moving on to A4, which is minutes of the last meeting. I'd like to ask if both RBKC and Westminster boards have their confirmation that the draft minutes of the 25th of March 2021 are an accurate reflection of the meeting. speak now or forever hold your peace, I think, on that one. Okay, lovely. So we are on to item A5. And I should say this is being presented by Anna Raleigh, who is the new Director of Public Health to the board and for both RBKC and Westminster. So over to you, Anna. Thank you.
Thank you very much, Councillor Kamali. I'm going to ask for the presentation to be uploaded onto the screen. Thank you very much. The first slide is giving some overarching headlines. Since the start of the pandemic, there have been 9,158 confirmed positive cases for COVID-19 in the Royal Borough of Kensington and Chelsea, and 14,428 cases in the City of Westminster. Following the second wave in December to January, case rates have come down in all areas. In the week ending the 18th of May, the Royal Borough case rate is 18 per 100,000, compared to 705 per 100,000 at the peak, and 17 per 100,000 in Westminster, compared to a peak of 610 per 100,000. Over the past week, we've seen an average of 4 cases per day in the Royal Borough and 6 cases per day in Westminster. Since the start of the pandemic, 265 Royal Borough of Kensington and Chelsea residents have sadly died with COVID-19 included on their death certificate. And that's within 204 within 28 days of a positive test. In the City of Westminster, 385 residents have sadly died with COVID-19 included on their death certificate. 297 people within 28 days of a positive test. No deaths have been reported in the last 2 weeks. Slide 2, please. This slide is showing a picture of the case rates across each of the London boroughs. The average London case rate is currently 19.2 per 100,000. And all London boroughs have a case rate below 50 as to the date when this slide was released, ranging from 7 in Havering to 48 in Hounslow. Second slide, please. This slide here is showing the 60+ case rate per 100,000 across London. And the case rate for people aged 60 and over years remains low at 9.1 per 100,000 in Westminster, approximately 4 cases per week, and 12.1 in the Royal Borough, again, approximately 4 cases per week. This here is showing the impact of vaccination in our older cohort. I'm now going to hand over to my colleague from the NHS, Joe Nigen, who's going to introduce a slide on vaccinations.
So I think Joe can't make it, so Simon's going to do it, is that right?
Yeah, Joe is underground. He's been called urgently to somewhere. So I was going to do a bit of an update. People can see some figures there, which they can absorb while I'm talking, I would suggest. I've got some notes from Joe that I'm going to talk to on behalf of Central and indeed for most of this West London as well. So I think the first area is around surge planning, and just to inform the board that the approach now really is to align vaccination with outbreak management and testing due to the variant of concern and risks across North West London. At the same time, we are actually seeking to bring forward second doses for patients 70 and over from 12 weeks to 8 weeks. There's a lot of local work now that PCNs are doing to make that happen. Residents aged 30 plus are now able to be vaccinated. There's an increase of vaccination capacity in Westminster of 20,000 plus a week, targeted around South Westminster, Little Venice, Marble Arch, and various other locations for pop-up capacity. And we're doing similar in West London. Our increase in capacity isn't quite as high because our PCNs are not signed up to do the cohorts 10 to 12, but that will be going through the mass vaccination site in West London. We're working collaboratively as a system, that is the local authority, public health, the NHS and the third sector. The latest messaging from, I guess, North West London and nationally public health teams is the sooner we get vaccinated, the sooner we can get back to normal. AZ, that is AstraZeneca, is safe for people to have the second dose if they've already had the first dose. National guidance is that people of 14 under should be having Pfizer or Moderna, and Pfizer is widely available at vaccination centres. There's a real push for people to get their second vaccine because we know that protection is significantly higher for people, particularly with the new variant. Once, what they say, the new variant, the Indian variant, once they've had their second jab. Just a bit of an update on what's going on this week. The by-borough vaccine bus has gone live today. And there's a schedule for the next 2 weeks where it's going to be spending 3 days a week in Westminster and 3 days a week in RBKC. Various other things going on. There's a real push in both boroughs to get as many pharmacies as possible signed up to the national system so that they can hold vaccine and patients book online to be vaccinated in them. We've had some problems, as we talked about previously at this board, getting pharmacies approved. But we have now got in double figures a number of pharmacies who are going back through the application process. There's, I think, 11 or 12 across Westminster and RBKC. And certainly we've also now got some pharmacy pop-ups happening as well. There's one in Bayswater that I know about where, whilst pharmacies are going through the national process, they are actually also under the clinical governance framework of a PCN being able to see patients and vaccinate patients on a pop-up basis. And there's various other things from Joe, but I think that I've probably said enough for now, so I'll take obviously any questions, or if Mona wants to follow up with anything, then I'm sure that she will.
Does anybody have any questions on the epidemiological update or on vaccinations at all? You can either put your hand up or write in the chat. Doesn't.
Yes, question.
Sorry, who's? I've got Olivia's hand up. Olivia, go ahead.
I'm happy to go after Councillor Nasvika.
I think go ahead, Olivia.
Okay, thanks.
I think your hand went up first, Olivia. Thanks.
Thank you, Councillor. We've heard positive feedback on the communication about vaccinations through the My Westminster in particular, and through the council comms teams. Our local committee gave some positive feedback about that it's consistent and it's coming through. So again, having these planned pop-ups is going to be very useful, I'm sure, because there is concern obviously about the considerable task of tackling vaccination in our boroughs. So some positive feedback on the communication that's coming through the council channels. That's all. Thank you, Councillor.
Councillor Butler-Thalastis, you've got your hand up as well.
Yes, I just wanted to say, I mean, it's great that the vaccination bus is happening and the pop-up clinics. It would be very useful if the vaccination bus had the Pfizer vaccine, or even if it didn't, it would be useful if it could be publicised which vaccine it has, because then it's easier to advertise on people who are under 40 if they can come as well. Also, it's a good idea to advertise as much as possible if people who are not registered with a GP, don't have an NHS number, don't have ID, can also come and be vaccinated at the pop-up clinics. I think when I ask, I'm always told that they can, but it's not publicised very much or very clearly that that's the case. Thanks.
Thank you. Simon, are you able to answer the point about Pfizer and about the NHS numbers ID requirements?
Yeah, certainly in relation to Pfizer, the hope is that it will be available on the vaccine bus, but there is work currently still ongoing to make sure that it can be safely transported. It is a very delicate, if that's the right word, vaccine, as we all know, and there's conversations going on, I think, nationally and at a Northwest London level to come up with appropriate protocols to make sure that it can be safely moved around. So I think the expectation is that buses such as this one will be able to administer Pfizer, but we're just not quite there yet. As far as unregistered patients, I mean, I think that we certainly, as you've pointed out, Councillor, do want to make sure we can vaccinate anyone who pitches up. Obviously, I think even, in fact, I'm sure that you will all see that today with the first day of the vaccine bus, there's been something of a rush for people to access the service. So I think that that's where the communications, we do have to be very careful because if the clinics are advertised too widely, we can end up with very large numbers of people, which is then extremely difficult to manage. But I think that under normal circumstances, wherever possible, that people who turn up will be vaccinated, regardless of where they're coming from.
Okay, thanks very much. We advertised the one in Soho quite extensively, so I hope that was the right thing to do. Thank you.
It seems like
Councillor Butler-Thass, it's just technically it's not in Soho, it's in Chinatown, which is in St James's Ward. There is one coming in Soho in a couple of weeks' time, although I don't think the date was confirmed previously.
Good point.
My apologies. Okay, Chinatown. To me, that's Soho, but there we go.
No, it was advertised in one of the emails that I saw as being that council compliance. So don't worry, but the historic part of that is no longer the case.
Well, Tim and I went past in a taxi today en route somewhere, and there were huge numbers of Chinese waiting for their vaccinations, which is encouraging.
Yes, very much so.
Thank you, and thanks for the clarification on the location. I see some hands have shot up. James, do you want to come in?
Yes, colleague James Benson, Chief Operating Officer for CLCH and ICP Director for the Royal Borough and Westminster. I completely agree with colleagues. We need to ensure that we adequately publicise to our citizens vaccinations, but we also need to ensure that we clear around what resources we have, that we don't have members of the public who are not socially distanced. I think it's great to see a huge response from our Chinese citizens wanting to be vaccinated, but we need to remember that we are still in a pandemic and need to make sure that we meet the needs of our population.
Thank you, absolutely, and it's good to see that there's such healthy appetite for the vaccines. One question from me is, well, in fact, it's a two-parter. The first one being, obviously AZ is for 40 plus. Are people who are eligible on the national portals, or 30 plus, able to make an informed consent to have AstraZeneca if they were to attend our vaccine bus, wherever it may be in the future? And then secondly, and I think it goes back to the communication side of it, all of our mass vaccine centres are still listed on NWL and most likely on all councils' web pages as being walk-in centres. But having worked in them this week and last, it's pretty clear that there is no walk-in facility available given the capacity issues. And I just raised that we should probably have a much clearer set of language around our mass vaccine centres. So over to you, Andrew. Thanks.
So certainly people can make the option to have an AZ if it's available, even if they're under 30. They can have a clinical risk conversation with a physician and make the choice to have AZ. But most AZ that's actually available at the moment is being kept for second doses for people who are in cohorts 1 to 9. So there may not be very much of that around. And I agree with your point on the walk-in centres, but that is just about managing capacity at the moment.
And thank you for your comment in the chat regarding being prevented from identifying vaccine type. I'm just reading that out for anybody that may be watching online. Thank you. Is there anything else on item A5? Otherwise, we'll move on to item 6. Nobody else? Okay, well, thank you to Simon and to Anna there for that update. And moving on to the Royal Brompton, I'd like to ask Dr. Richard Grocott-Mason and Robert Craig to present their update. Thank you.
Thank you, Councillor Kamali and board members. I will try to share some slides. I don't know if this will work. Maybe I don't have permission to share slides.
Yasmin, do we have the slides on our system that we could present on their behalf?
No, I don't have the slides, I'm afraid. I mean, I can update them after following the meeting. I can send them to the board and put them on the website.
It's no problem. You have a paper, a briefing paper, so I'll talk to that. And there were only a few slides just to make it slightly more interesting than looking at me or looking at the list there. So thank you very much. My name's Dr. Richard Grocott-Mason. I am the cardiologist and the managing director of Royal Brompton and Harefield Hospitals Clinical Group, which, as you know, are now part of Guy's and St Thomas's Foundation Trust. And thanks for the invitation and the opportunity to speak to the board and update you on what we've been up to, and also on the flexibility around the agenda. You have the paper, as I say, and I'll take that as read and happy to take questions. For those people who may be less familiar with Royal Brompton and Harefield, we are specialist hospitals. We treat patients of all ages who require specialist heart and lung care. I was going to show you a picture of a heat map which shows where our patients come from. And although our patients are concentrated in London and the southeast of England, we have patients from all over England, Wales, and also international patients. And this referral pattern hasn't changed since we have become part of Guy's and St Thomas's. About 24% or so of our patients actually come from within Northwest London. I also would show you a slide of our contribution, or the pattern of contribution within the COVID over this last year, which has been a pretty extraordinary year. We've during the peaks of the pandemic more than doubled the capacity for our critical care, and we were looking after some of the sickest patients who had COVID. The patients that we treated either came from other intensive care units in Northwest London or London, because to relieve some capacity within the critical cares, and the Northwest London ICS system worked very well, I think, in this regard during the peaks of the pandemic. And we also were a national provider of what's called ECMO for those patients where the lungs are so badly damaged that even on a ventilator they can't get oxygen into the blood, and therefore needed to be oxygenated by an artificial lung, which is so-called ECMO. And at the peak of the pandemic, we had 28 patients on this level of support, which is hugely intensive nursing. I'm pleased to say that the outcomes have been really good, with survival rates of over 70%, but we still have 3 patients who are on ECMO and have been on ECMO for several months. So there is a long tail of patients who are critically ill from the pandemic. And at the same time, at both hospitals, we've continued to treat patients with non-COVID heart and lung disease. Unfortunately, data from ONS shows there has been I think something like a 5 or 6% increase in cardiovascular mortality during the pandemics because of a variety of reasons. But these are the non-COVID casualties of the pandemic. But we've continued to treat patients with heart surgery, transplantation, and lung cancer surgery. A word about the staff. Our staff have been fantastic during during this pandemic, as always, but have really stepped up to the plate. They are the most important asset that we've got, and as an organisation, we've made a really significant investment in staff health and well-being during the year. And we've outlined some of those things in the paper, but it includes staff psychology support, critical incident debriefing, listening, a variety of other well-being measures. We, through the charity, have produced a badge, which I would have had a picture to commemorate everybody who's made a contribution during the pandemic. It's been, as for everybody, a pretty stressful, emotional time, and as well as dealing with the pressures that staff have had at home and in their family lives and in their social lives, caring for patients in this type of environment has been really pretty extraordinary. And we also have quite a lot of overseas staff who've had the added problem that they haven't been able to travel home to see their families, which would normally be part of their recovery period and the times. We also have done some innovative things. We had a project with a charity, No More Heroes, around an innovative art project where staff were using pictures that have been taken during the period to record and speak about their emotions and their experience during this time. I'm going to hand over to Robert, who's just going to give a bit more detail of some of the things that we're doing, and then very happy to take questions. Robert.
Thanks, Richard. My name's Robert Craig. I'm the Director of Development and Partnerships at Royal Brompton and Harefield. Thanks, as Richard said, thanks for the invitation to be here this afternoon. I'm just going to update the board on a couple of issues. One being perhaps a bit of a focus on our children's services, and then perhaps finish with two current developments at Brompton Hospital, which I hope will be of interest to members. Firstly, as far as services for children are concerned, they've been a particular focus for us of the collaboration between ourselves and Guy's and St Thomas's over the last 12 to 18 months or so. And I think an important thing to brief the board about is the fact that we worked together throughout the pandemic to ensure that treatment, and especially surgery for children with congenital heart disease, was able to continue unaffected throughout the pandemic, whether in the first wave of pressures in the spring of last year, and indeed through the autumn and winter that we've just gone through. And that was a great testament, I think, to the resilience of staff, but also of the collaboration between the two hospitals. And it's led to some longer term advantages as well. And I'll just point out a couple of those. One is that we now have a permanent joint multidisciplinary team for specialist cardiac treatment between Evelina and Royal Brompton. And that means that the expertise of both hospitals is available to patients of both hospitals, which wasn't always the case before. And it also means there are additional greater options for mothers who are delivering babies with congenital heart disease. They can choose to deliver either at Queen Charlotte's or Chelsea and Westminster or St George's or wherever they may have first registered, or indeed if they need to at Royal Brompton, or indeed at Evelina, where the maternity services are co-located with the congenital cardiac services. So that's been a step forward in the services that we're able to provide. But I think it's also important to emphasise that whatever happens to the future location of children's services currently at the Brompton service will remain part of the West London Children's Alliance. And that's a long-term commitment that we're making. And in particular, that's working with experts and colleagues at St Mary's Hospital in Chelsea and Westminster. But I don't want there to be any doubt about that longer-term commitment. I'll talk just briefly then on a couple of other current developments at Royal Brompton. One is a new imaging centre, which will open at the beginning of 2022, so in about 6 or 7 months' time. We would have shown you an artist's impression of what you will be able to see from Dovehouse Street in a matter of weeks when the scaffolding and monoplex sheeting is taken down. And there's a 4-storey building, but don't worry, 2 stories are below ground and 2 stories are above ground. And we're excited about it because it brings together quite a lot of the specialist imaging that's currently scattered around different parts of the Brompton campus. And it will be state-of-the-art imaging that helps with faster diagnosis and more complete diagnosis of specialist conditions that many of our patients have. And I should say that it's been made possible by the planning agreements that were concluded a number of years ago between the Trust and the Royal Borough. And so we're delighted to see that to come to fruition just in a few months' time. And then finally, a word about further collaboration between Royal Brompton and Royal Marsden hospitals. I'm sure many, if not all of you on the call, will know that we're long-standing partners as well as near neighbours with mutual support across Cale Street and Dovehouse Street in Chelsea. But in addition to that long-term arrangement, we've just agreed a formal long-term partnership for a joint thoracic oncology service, which focuses on cancers of the lung and the chest, and provides us, both hospitals, with opportunities to make what we hope will be lasting improvements to the service that we offer together. And both organisations see clinical and research advantages in the collaboration that we've concluded, and we're both making a long-term commitment to the future of this service in Chelsea. I'll stop there, and I'm sure Richard and I'm certainly, and I'm sure Richard also is happy to take any questions that members may have.
Thank you. I see the first hand up is Councillor Rendell from RBKC.
Thank you, Jim. Thank you, Richard. Thank you, Craig, for that very comprehensive view of the Royal Brompton going forward. I just have a couple of questions. So I'll declare an interest. I'm the ward councillor for Stanley, of which the Royal Brompton is in. And I note in your report on section 2 of the update, it says we anticipate that Royal Brompton will remain on its current site for a significant period, at least a decade. I just want to get assurance that is the case, because I've heard many things going around, and obviously you'd be able to confirm or deny those rumours. Anything from 5 to 7 years, the site could be moved out completely, and obviously the site vacant there. So that's the first question. The second question is, how will the move affect, and I know you mentioned it earlier, the children's services there, because obviously that's what's quite renowned, and I've been on the wards and I've seen the great work that your doctors and nurses and all staff do there, and how that will continue, and how you will go about communicating that to future patients, that site there, obviously, which is much beloved, it's got a great garden next door in St. Luke's, etc., as a bit of recuperation, how that will continue. And the third question is, just explain a bit more about potential partnerships. I know you've got it on the report, but how with Marsden, with Chelsea Westminster and Imperial, whether they may be able to use the site in the future, or what your kind of plans are around that particular element. Thank you.
Thank you, Councillor Rendell. Shall I have a go at those? I mean, obviously each of those could have quite a long answer, so I'll try and be short and try and give you the assurance you're looking for. So we have, as we said, there are no plans to move away from the buildings, and any plans that would involve that would be long term. So I'm very confident that for at least a decade the services are not moving. The imaging centre that we have, Robert was talking about, I think is a long-term asset that will stay permanently in the area, delivering ambulatory care. I think where there is perhaps some confusion around the 5 to 7 years that you mentioned about, and it's also relevant to your question about children's services, is that it is likely that children's services, inpatient children's services, will move from the Brompton site in that sort of time frame, depending on new facilities being built at the Evelina. That is not changing that's not closing a building, that's moving the children's service, which, as you may recall, has because of the commissioning standards of NHS England around wanting children's surgery, inpatient surgery, to take place in a comprehensive children's hospital environment where everything is co-located. What we are working on is a plan to develop the ambulatory outpatient children's service that would, again, remain long-term. It's the inpatient co-location of services that NHS England require us to move when other facilities are available. And that we expect there will be a public consultation on that move of service potentially later this year. It's an NHS England run process, not our process. In terms of partnerships, in a sense, nothing has changed in our relationship with Chelsea, Westminster, Imperial and other hospitals within North West London. And during the COVID pandemic, I think that the relationships and the working arrangements was as good and as close as it has been. And obviously, as the ICS legislation, as that develops and matures, we are working out our new working relationship with the hospitals around and about. But as Robert indicated, the virtual children's hospital between Chelsea, Westminster and Imperial that is being developed, our clinicians are providing support and working with the clinical teams in terms of looking at potential appointments to bolster the services for heart and lung patients, children within North West London. I don't know if Robert wants to add anything or if I've missed anything out on your questions. I think I covered all 3 points.
I think so, Richard. Thank you. Sorry, Robert.
No, I was going to say nothing to add unless there's a
fantastic
question.
And I'm sorry, I called you Craig earlier. I'm so sorry, Robert.
It's an occupational habit of having 2 first names, so please don't worry.
I'm so sorry, but thank you.
Thank you for the question, and thank you both for your presentation. I suppose as I don't see any other hands, the only thing left for me really to say is that we would, of course, welcome somewhat more detailed plans going forward. The vague in a decade or at least a decade doesn't fill us with much confidence, and we would really appreciate an open discussion about the true plans and the true consultations which are likely to come forward, so that we can, of course, make plans accordingly for diminishing a service in southwest London. Other than that, I don't see anything else. So I suppose just to thank you both for coming along and look forward to picking this up at another time, as we have at least a decade to discuss it. So thank you very much.
Perhaps I could just respond to that in that I would not want you to have the impression that we've got some secret plan that we haven't shared with anybody. There is no secret plan. We are again evaluating what is the right estates option for our services, which are to deliver high quality services. And there is a lot of learning that's happened through COVID, where a lot of the health estate in London has been shown to be not as ideal for dealing with this type of pandemic. The demand on critical care, the ability to keep patients safe from infection whilst you're maintaining non-COVID related pathways, has put a huge strain on all of the health services across London. So I think there is a question about the provision of critical care, the design of hospitals. Technology has enabled us to do care and support our patients remotely without needing them to visit the hospital as much as they used to do in a traditional way. So all of these things are being are factored into the evaluation of what services do we need to provide and where do we provide them to support the sort of services that we deliver. And we're very happy to have an ongoing, and indeed we've met several members of RBKC to to update you on our thinking and our plans, and very happy to continue that dialogue.
Thank you very much. I think your paper makes clear you have a vision for service relocation. It's only 3 miles away. I suppose what we would like clarity on is the vision for the buildings and the site itself once those services have moved, at whatever point that would be. But anyway, as you say, we can take that up at a future meeting. Thank you very much. So then we're moving on to item 7, which is the Health and Wellbeing Strategy Refresh, Position Statement and Health and Wellbeing by Borough Boards, presented by Chanel Arcott.
Hello, thank you, Chair. Good afternoon, everyone. I'm Chanel Arcott. I'm the Director of Health Partnerships in the Royal Borough of Kensington, Chelsea and Westminster City Council. This is a very quick update to the board on our health and wellbeing strategy. As part of its statutory duties, the board has a requirement to oversee each borough's health and wellbeing strategy. The Royal Borough Kensington and Chelsea strategy expires this year, and the Westminster strategy is due to expire in 2022, which is next year. So we've been working on our new strategy, but as you know, we've been deeply involved in fighting the pandemic, and this has increased demand on our services and resources. At the same time, we're seeing a significant restructuring of NHS around us. And within this changing landscape, as a statutory body, the role of the Health and Wellbeing Board is also changing. So we anticipate the role of our board, Health and Wellbeing Board, to oversee the local health and care delivery and take an active role in shaping the future of services and the service delivery in a more strategic partnership and integrated approach. So our ambition is to incorporate these changes in our learning from the pandemic into our new joint Kensington and Westminster Health and Wellbeing strategy. So I'm just here to I would like the board to note the proposed continuation of the current strategy for RBKC, pending the launch of our joint strategy, which will be presented to the board in the next future boards meeting. So I'm stopping here, and if there's any comments or questions, I'm happy to take them.
Thank you. Yes, Olivia, you've got your hand up.
Thank you. Really welcome the paper and the valuable role of the Health and Wellbeing Board. Chanel, I wonder, is there anything more you could add about its role in the ICP at the moment, and where you see that being a route for voice and that local context?
We've got an ICP paper coming up, but briefly, the role of the Health and Wellbeing, of course, the Health and Wellbeing Board is the only statutory board that remains locally since the transformation of NHS. And this is the platform for our partnership working, and the board has a responsibility to make sure that we work in an integrated way and we deliver integrated, outcome-focused, patient-focused services. So this all fits in really well within the aims and the purpose of the ICP. Therefore, as I said, our ambition is to make sure that the board has an oversight of the ICP activities and the priorities, and has regular updates from the ICP on the developments of the work locally. Thank you.
Thank you.
Do we have any other hands? I can't see any. We do have a question from an RBKC resident, Tanya, about the IT system, but I imagine this was regarding the Royal Brompton, I presume, Tanya. I don't know if you're able to confirm either in the chat or not. Yes, it was. So I'm sorry to have not pick that up whilst they were still on that item. I'm sorry. We'll take that away and get an answer for you on that one. Thank you very much. Thank you. Do we have any other questions for Chanel regarding the Health and Wellbeing refresh? Nope. Okay. Well, thank you, Chanel. I think everyone's in agreement with you then on that one. So we'll move on to item 8, which is the, as it says on the screen, the ICP structure, priorities and relationship with the Joint Health and Wellbeing Board. Oh, I'm getting a little bit of echo. Sorry, James. And yes, I will be asking James Benson, the ICP chair, to present an update on the structure and priorities and the relationship with the Health and Wellbeing Board. When we asked James to present this paper, it should be noted that we had asked how population health management approaches are being applied in the identification of the priorities. What are the health and care priorities for our population post-COVID and beyond? What was the evidence behind why you chose these priorities? How are these priorities will address the inequalities and will improve the lives of all those communities in the boroughs? And what measures and indices will be used to measure local success? Of course, it should go without saying that we're keen to continue working closely with NHS colleagues as they develop their priorities, and welcome that you've brought this for discussion. So, James, if I could ask you.
Thank you, Councillor. Can I have my slides, please?
Apologies, I don't have the slides up. They are online.
Okay. Let me see if I can share.
I'm sorry, James, this seems to be a similar issue as before. So for the benefit of everybody else, all the papers are on our website.
Can people see them? So I can't see you now, but I will go through them. Councillor, can you see these?
Yes, we can.
Okay, great, wonderful. Right, I'm on try and get to the first slide. So I'm going to start with the fact that our ICP is non-statutory in and of itself, and I think Chanel's previous paper and discussion is really helpful to set the scene of where we're at today. The NHS is undergoing significant change, and there is a clear desire, I think, in all parties to work together in partnership. But I think we would all recognise that we have and are living through the biggest pandemic that we have seen in our lifetimes. But we have an existent strategy, and Chanel has briefed us on the need for those to be replaced and reviewed. But we also have some significant learning coming out of the pandemic. My slide identifies, just for people in the meeting, the types of things that we would consider as an ICP. So we have neighbourhoods of around 30 to 50,000 people that are based on primary care networks largely and have a relationship to our wards. We have integrated care partnerships, which we in the Royal Borough and the City of Westminster see as our two sovereign places, and we would be looking to work together in partnership as we build some of the changes that we feel that we need to put in place. And we have integrated care systems, and our integrated care system is North West London. Chanel identified that we have a health and wellbeing strategy, and that's reviewed by this statutory board, and our strategies already identify the sorts of things that we would want to be working on: improving lives for children, reducing risk factors of long-term conditions, increasing sustainability of our health and care system, and really supporting our children and families to live a better, more healthy life. So this has been important because when I come through the next slides, I think people in the meeting will identify how we've come to some of the things that we think we need to work on. So we're reviewing that. We've got a very rich data set in terms of public health indicators. We recognise that some of the big challenges that we face in our communities are around obesity, diabetes, hypertension, and severe and enduring illness. And we have a level of data that brings it down to our ward levels, that describes the needs of our population. And it's important that we understand that, because the way we deliver health and care moving forward will be based upon public health management. And we have a plan to develop how we will deliver that in our primary care networks in partnership with our community mental health providers, our GPs, our acute trusts, our voluntary sector, and other partners. But we do have, if I just go back to this slide, a number of key principles that we need to deliver as part of our ICP. And these have been set for us as a North West London priority. Clearly, we need to manage public health management, and the way we're going to do that is going to need significant work. People on the the meeting will identify that we have the WSIC database, which is rich in data, but we probably need to think about how we practically use that. How do we derive information out of it? How do we practically use it to make change between health and care? We also need to develop our primary care networks and embed clinical practice within those and clinical leadership around our place. We need to review and improve our diabetes care. I think we all recognise that diabetes in and of itself is a significant public health need, and it's something that we are committed to delivering in North West London. And we also need to really think about how we deliver our model of community and mental health services so that we can wrap that around our primary care networks and reduce duplication and improve outcome. The other thing that we have already touched on in this meeting is our need to manage vaccinations and vaccine hesitancy. And I'm really pleased to see that whilst we've communicated particularly well already around vaccines that are available, we need to do more to tackle vaccine hesitancy in all of our populations, including those populations that are hard to reach. In developing our local priorities, we have paid attention to the strategy and really thinking about what we need to learn from the pandemic. How do we work together to ensure that we maximise health and care delivery at place? How do we do that to reduce the duplication of effort? How do we support our residents to stay at home and when they are in hospital to be discharged safely and effectively in a quick and timely fashion and to keep them at home and well? And how do we manage our local care priorities? We've identified, therefore, a number of key areas that we think we should work on, and those around children and young people, our mental health, obesity, care homes and how we support our residents in care homes, and discharge. Those key priorities will be added to the priorities that I discussed before. They're on the second slide. But these are our suggestions. We have looked at our ICP priorities and compared those to the high impact areas that are identified in our strategy, and they marry for both Westminster and the Royal Borough. And we've started to work on some project plans that look at the key areas that we have identified. We are working through measures for consideration, key performance indicators, and a project plan for each. Our plan is to take those to our first partnership board. Colleagues on the call will recognise that because we are not a statutory board, we have no authority but the authority that we hold as individuals and as partners to deliver improvements for our citizens. I think the challenge that we face is how are we going to do that together? How are we not going to be a talking shop, but actually a board that delivers real and lasting change for our citizens, and how to report those changes back here to the statutory board that we are in. Colleagues have written today to a variety of partners to garner their support to join our partnership board, and we will be looking to establish one per month, one for the Royal Borough and one for the City of Westminster. So there's really a bit of an ask here today. How do we engage with the Health and Wellbeing Board? Do we think the priorities that we have set echo the health and wellbeing strategies? How should we continue to do public engagement? And how will we ensure that the voice of the citizen is amplified as part of our ICP?
Thank you, James. And I see we already have a hand up from Councillor Mitchell, so I'll go to him.
Thank you, Jem. James, could I take you back to your slide 5, please? And particularly look at the local need and evidence-based approaches, and that your first bullet point there. And as you know, particularly in the pandemic, the inequalities across both boroughs have very much been brought into focus by the vulnerability towards COVID. Could you explain how population health management approaches are being applied to the identification of these priorities, and this one you've highlighted here is obesity, but could you actually take the Health and Wellbeing Board through that particular process which involved identifying the priorities like obesity?
So I would suggest that our public health management approach needs further work, which is why it is a key plank of the work of North West London, because we need to manage the use of that in our PCNs. What we have done is, as myself, Dr. Andrew Steeden, Mona, the two CCG representatives, and Bernie Flaherty have identified that these were the key areas that we wish to work on as a proposal in the first instance, and then to look at how we would embed public health management as part of the approach. These are our suggestions at the moment. These are not set in stone, but we must start somewhere in terms of these key areas. If I could ask my clinical colleagues to come in to answer the very specific point that Tim has asked. Andrew?
Yes. So the obesity, I think, came out of a joint, out of some of the work that came out of the JSNA work that informed the health and wellbeing strategy before. So particularly amongst children, which is why So what we have done in practice is transfer some of the priorities from the various organisations that are partners in the ICP to become our initial priorities going forward.
James, could I just touch on, and I know there were further discussions, but it's the governance point. You mentioned about both boroughs having partnership structures in place. What is the timeline for that and the relevant local committees and other governance structures as part of the new arrangements?
So those meetings are occurring next month and the month after, one for each borough.
Okay, thank you.
Bernie, I see your hands up.
Thank you. I was only just going to supplement something that James said, if I may, as one of the members of the ICP. It was on Councillor Mitchell's point about population health and health inequalities. It's so important, and James did a very good job saying this, that this is about us looking across two boroughs about our health inequalities. There've been health inequalities for quite some time, but it's shown a spotlight over this time of COVID. And obesity is one of those areas that we are an absolute outlier for the worst reasons. You know, we have some of the largest numbers of younger people with obesity. So it was something, I think, as a group, we absolutely, when you see the heat maps, you can see that. This is something we need to grab, and we need to tackle the inequalities that's happening in these areas. So it is really important to land it with population health and inequalities, and not just because there's a long list of things we could actually do. This is something that we can come together as partners to make a difference. And the others are the same, but obesity, just as you raised that, I thought that was helpful. Thank you.
Is anybody responding to that? A few microphones have gone live. No? Okay, in which case, Olivia, you've got your hand up.
Thank you, Chair. I'm sure James can predict my question, which is, to make this work, it needs to work for local people. Without their understanding of the systems that we now have and will be having in place, and their access and such like, and without them feeling an active involvement in shaping what priorities are, it's less likely to be successful. So I'm just wondering if you're able to say at this point how that might happen. Either is that around PPGs or PCNs, or have you been able to draw some of the work we did with Central London previously in discussing the borough plan?
Olivia, thank you. It doesn't surprise me. We've discussed this. I think that is a topic that we need to discuss in our partnership board in the first instance, because I think, as you heard me say the other day to your PPG forum, our patients are our citizens, and they are the same patients often of the provider trusts at the same time. So how do we coalesce our patient voice within the PCN, so the primary care network? How does that relate to those individuals as citizens of wards, and how do we practically hear that voice so we don't ask them multiple times? And it's something I think we need to discuss and debate as partners together, rather than anyone set out and say this is what we should do. Olivia, I think there is something for us about how we directly ask our population how they wish to be engaged and involved on these sorts of projects, but I'm keen that we don't not do something around some of these very key priorities around health and care. We need to start the work, and what we'll be looking for from colleagues who are developing plans in these areas is how do they wish to have the voice of the public recognised in their work around these key areas of change.
Thank you, Councillor. Could I come back on that? And I think it's that informing, so people are understanding the context in which health and social care are working, their statutory responsibilities and the challenges. And I think people are very welcome, really are open to that and open to understanding the context and the challenges and helping to arrive at some of those priorities.
Agreed.
Thank you. Ian, I see you've got your hand up.
Thank you. Hi there. I've just got a question round about the priorities I'd stated in the presentation. So particularly things like kind of sort of obesity or older people or rough sleepers. I mean, a lot of the factors influencing that are the wider determinants of health rather than just the health impact. And I'm wondering, how do we see that the ICP either influencing or directing activity to influence those wider determinants of health to have the impacts that you're wanting, as well as working with the health people that are on the ICP?
So Ian, as we develop our ICP, it is not just going to be about health, and you and I touched base on this the other day, which is why I have asked for a variety of people to come together in a partnership board, which is a board of people doing things rather than necessarily doing the talking about things and the outcome. I think the big change that we need to do is work together collectively to deliver that change. Similarly, at the same time, I have asked the CCG leads to write to partners. I have asked for a weekly conversation with partners in both Royal Borough and Westminster to start to build an understanding of what is happening in our place around health and care. And this is probably based upon my belief that if people understand what is happening in their place in terms of either health or care, they are more likely to be able to come together and work together to drive real and lasting change. And then we can really start to engage with our citizens around what it means for them. One of the big learnings of the pandemic was if people come together and talk, we might actually get something done which is greater than our singularity of organisational structures. And I'm very keen for us to continue that piece of work, because in coming together on a weekly basis, I think colleagues, partners will be able to work together to deal with some of the challenges that we face. So there was some of the colleagues on the call will recognise that we had a call just before now around the vaccination bus that was in Chinatown. Lessons learned, things that we need to think about. It was, I think, really powerful to hear and understand what it's meant and look like for partners and for our citizens and their ability to access vaccinations.
Thank you. Dominic, you've got your hand up.
Yes, thank you, Chair. Dominic Conlon, just in Westminster. Firstly, a couple of observations. Firstly, really pleased to be invited to be part of this partnership and the sort of operational group and board that James is talking about. And then just for a bit of assurance to the wider board, we've done a review. We have our own quality priorities, as I'm sure Imperial and other provider trusts do, and there's a huge amount of overlap between these in terms of diabetes, particularly in terms of children and young people. So I think one of the things we can bring to this, just a bit of assurance, is a bit of kind of end-to-end work where we can start to look at both the population end and then how it drills into how the system is used and making a real impact. Second, and two other broader observations, actually the point that was raised there about the social determinants of health. I think as we get into the medium and long term, the principles of the Anchor Institute type work and how we start to change the way in which we work, not just as health and care providers, but in terms of our ethical approach, our role as a large employer, our role as a sustainable employer, etc. A lot of things I think we can bring to this to try and address the points that you've just raised there, Councillor. And then finally, just to pick up on Olivia's point, one of the great joys about working in a provider across North West London is you engage with a number of these partnerships. And actually the Hounslow ICP has made effectively the active community solution, the active citizen solution, one of its priorities. So that rather than just doing the engagement, actually it is actively looking at how self-help and how the role of the citizen itself can be part of the way in which we work. And I just think that's sort of food for thought for us as we take that forward in terms of our establishing our work programs in the medium and long term.
Thank you. I'm not seeing any other hands up. I see Chanel's made a comment that the ambition should be to work towards creating a bi-borough joint ICP, and I wonder if you could answer that, James.
So I think we should work in partnership. We would need all partners to come together and realise that as a reality. I think if we set out and say that we will do it, it sometimes creates antibodies. So I would prefer us at the moment to work as individual ICPs and then come to that reality. A number of us, and I think Dominic said this, people recognise that I'm the Coolba Trust that spans 4 ICSs, so has 11 London boroughs. I would prefer us to focus on improving the health and care and supporting our citizens in the first instance than worry about whether or not we have a single ICP or 2 ICPs together. We will deliver our ICPs by delivering improvements for our citizens, and if we focus on that, we may then develop a bi-borough ICP. But all we can do is wait and see.
Okay, I'm not seeing any other questions, so I'll ask mine. Oh, sorry, no, I spoke too soon. Lena, you've got your hand up.
Thank you, Chair. I'm sorry, I've just belatedly decided to come in because I got a bit heated listening to all the comments, which is quite inspirational because I'm really, really impressed to hear such amazing support to health inequalities, starting with Councillor Tim Mitchell. Thank you for raising this issue. I'm also glad to note that ICP includes PCNs, and PCNs for us is GPs. And the first point of contact for our patients, citizens, residents, whoever you want to call, are the GPs. And whilst I appreciate the importance of wider determinants or social determinants contributing to people's health inequalities and so on, first point is GPs. GPs continuously get under-resourced, and GPs are in a very strong position to play an amazing role to improve health and well-being of our patients, residents. But the access is getting increasingly reduced. And unless we tackle the resources that GPs are suffering from resource constraints, immediate benefits that our patients can realize are being denied. And I really want us to talk about or consider how GPs could be supported and strengthened to play a more preventive role, and that's exactly what our deprived communities in our deprived areas immediately need. And the access to GP services is getting increasingly problematic and reduced, in fact. And first of all, to begin with, BME communities' health-seeking behavior is quite poor. But now with increased education and in the community, they are ready to seek support, health-seeking support, but it's not available anymore in the way that they need.
Councillor, would you like me to respond to that?
Yes, I think so. I think there's a natural overlap with GPs and our borough boundaries.
Yeah, Mona, would you like to come in first? Or you're on mute, Mona.
Yes, I was just going to say that it was good that Lena brought up this point. I think one of the learnings from the COVID and the vaccine hesitancy program has been the work that we're doing with local authority colleagues in general practice. I think that's a really positive thing to take forward for all the other areas, whether it's screening, whether it's the other public health related aspects. So especially with the BME communities, along with the other communities. And I think one of the pieces of work that we started talking about in the ICP with, Andrew, myself, James, and the borough directors was about developing a piece of work that would be future-proof to discuss and review the health inequity within both the boroughs and how we would approach that in a manner that would probably, there might be a bit of molding that is required for different programs, but generally something that would address the inequity, whether it is in vaccinations, immunization, screening, cancer, all of those above, and that we could use again and again. And I think that that's probably what you're referring to, Lynn. I think that is what this vaccine hesitancy programs really brought to light for us in primary care, that we do have all the support out there in the local authority, and we need to use it in a sort of a much more structured and synchronized manner.
Mona, I think that's really helpful. I think I would also identify that over the next year, we have additional roles coming into primary care that we are looking at deploying staff into, some of those being mental health practitioners to support our primary care colleagues to release time and support them with resources. I would also reflect to this board, our primary care colleagues at the moment are very busy. I don't believe that they are reducing access, but at the same time as trying to attend to the health and care of our population, they are also needing to lead on some of the vaccination of our population. And my genuine thanks to them for that work.
Thank you again. I'm waiting for hands, but I don't see any. So I suppose just a few points from me. I picked up earlier that you mentioned we're looking at the WISIC data in order to assess where the inequalities may lie. I think the last few months have shown, both Westminster and RBKC, that the WISIC data has multiple flaws within its refresh rate, its cleansing, and its general maintenance. And so I suppose it's imprudent to make a plan based on faulty basis. I'm sure some of the underlying issues are, of course, correct. But I wonder, firstly, what is our plan to address this going forward so that we're all working from correct information? And then secondly, I can't quite get my head around the overlap between having two ICPs. I see in the chat that Mona says, allow for a by-borough to organically evolve. And I suppose my question would be, given that our PCNs straddle boroughs, how would that organic involvement demonstrate itself, and what would we use as evidence to say that a single ICP would be the more logical way forward?
So Councillor, if I deal with those questions in order, I agree, and I say this as a Chief Operating Officer. The data you get out is only as good as the data you get in, and therefore we are having conversations at a sector level about how we improve the use of WSIC and the actual data that's in there. But we already have existent understanding of the health and care of our population via our strategy. And some of these things we have known, as Bernie has identified, for years. We know the populations, we know where they reside, and we now need to get into those populations. And that's why colleagues in the ICP will hear me said this before. It's not just about PCNs, it's about wards, because people live in their wards and they are part of a PCN, and they're not necessarily mutually inclusive or exclusive of each other. So, I think we therefore need to use whatever information we have to start the work rather than relying on single sources. In terms of, should it be one or should it be two? I think it's a conversation that we will be having in our first partnership board. I wouldn't want to sit here in a public meeting and say to anyone, of course, we will have a by-borough ICP. We do need to discuss this as partners and ensure that all partners feel comfortable with that position. If they don't, we will work through that. But we need to have that conversation.
Mona, you've got your hand up.
Yes, thank you, Councillor. I think just to add to James's point, I would also stress that the PCNs within the two boroughs are at different levels of maturity. So I think that's another point. We've got to bring everybody along with us. And that's what I mean by the organic involvement. We need to sort of get to a stage where, plus with the vaccine program, we've been really focused on that. But as we start coming out of that, we can get back to looking at the joint priorities in both the boroughs. And we can also be looking at getting the PCNs, which are going to be the driving force behind this, to get up to speed at the same level. And so that's what I mean. I think it isn't something impossible, but it just needs to happen at the right pace.
Thank you. And Andrew, you've got your hand up.
Yeah, just to concur, really. I mean, I think it's very telling that for the by-borough, 3 of the 4 partners in the ICP are joint partners across the by-borough. And we have written, we're beginning to write a strategy which is going to be shared between the boroughs as any early ICPs anyway. So I foresee that the ICPs will come together, and we'll make every effort that they do that over time.
Thank you. I think that would be an interesting topic for us to pick up on as this all develops. If there aren't any other questions, just a final one from me really is I think we should celebrate the joint working that we've made over the vaccination effort between local authority, the NHS, and the PCNs and GPs and everybody. I think this is really a testament to the ability that we can do it. And so I suggest going forward that we really do have proper engagement with data sharing agreements, making sure that our local priorities are matching with the slightly wider ones. And so I would like to keep this conversation quite live and quite active, and I sort of put that to the board here, that we do sort of keep this as an ongoing item into the future. But otherwise, I don't seem to have any other questions. So I suppose just to say thank you to James for the presentation, and we'll move on to item 9, which is a cancer screening and recovery update presented by Director of Public Health, Anna Raleigh.
Thank you, Thank you, Councillor Kamali. I'm very pleased to introduce this important item. As colleagues know, the COVID-19 pandemic has had a significant impact on the delivery of NHS services, not least on cancer screening services. So it's very timely that we have the opportunity to look at these services here today. Just in terms of responsibilities, I just wanted to set out that NHS England is responsible for commissioning the NHS cancer screening programmes, and the local authority public health maintains an oversight role to review trends, highlight concerns in order to ensure adequate delivery of the screening services to the local population. So hence the joint approach we're taking today in terms of presenting these papers. I'm really pleased to welcome Dr. Kathy Benesh, who is the NHS England screening lead, and she is joined by colleagues Suzanne Sinclair and Claire Barry from RM Partners to give an overview of the impact of the COVID-19 pandemic on our cancer screening services and on our recovery plans. So the Health and Wellbeing Board are invited to consider the reports, to comment on the recovery plans with reference to the local context which is set out in the background papers that people have. The Health and Wellbeing Board might also wish at the end to consider and agree a timeframe for this discussion to come back to the Health and Wellbeing Board when we have more updated and publicly available cancer screening data, and that will help us to further review local action plans and to scrutinise and monitor progress moving forward. I'll hand over now to Dr. Benesh.
Thank you very much, Anna. I'm not quite sure how much of a presentation that you want, or whether you would rather, I'm assuming people have read the papers, would just rather me comment on the papers. But briefly, just to say that we needed to pause our services during the first lockdown. We did keep them going as far as we can, and where we knew that there were people at particularly high risk, then as far as possible, we kept screening those people and passing them on for treatment if that was required. Since then, we have been recovering the services to catch up with where we should have been. And I'm pleased to say that for the bowel screening programme and for the cervical screening programme, that we have either recovered those programmes or are very close to getting back to where we would have been. The breast screening programme is proving to be more challenging, and in line with the national expectations for this, we anticipate that this programme will be recovered by March 22. I think that was all that I wanted to say. NHS England and Improvement have been putting a lot of resource into recovering the breast screening programme, for which we are very grateful, and it looks as if we are probably in a very good position compared with the rest of the country. So I think I'll leave it at there, and I'm happy to take any questions.
Thank you. I seem to have a hand up for Andrew, but that might be old. I'm not sure if you can confirm, Andrew.
Yes, sorry, I'll take it down.
Thank you. Okay, Councillor Butler-Thalasis.
Hi. Yes, in the papers, the issue of cancer screenings amongst BME groups was mentioned, and I was wondering if there were going to be any particular initiatives to increase screening in those communities. I'm not sure whether this will be for me to take, or whether this one is probably the area that Susan and Claire were going to talk about in the other paper. But sorry, that's probably my mistake. It's okay. It's a bit confusing, but certainly from our perspective, I have been as part of the recovery, I have been concerned that we will be increasing the inequalities within the screening programmes, and particularly the breast screening programme. And we have been looking at the inequalities, and we have mapped those. We're planning to do that for all of our screening programmes, and then we will be able to focus interventions specifically towards those areas where we are seeing that we are having problems with women or men being able to access the programme. So yes, we do have that in mind.
Thank you. Thank you. Olivia, you've got your hand up next.
Thank you, Chair. Just a brief question about cervical smear testing. I know in the past our boroughs our figures have been a bit skewed, or we've been lower than we would have expected. I just wondered if you've got any comments on that, or that may have improved, but certainly it was a challenge in the past.
Yes, I think it remains a challenge. I think what we have been seeing gradually over time is that there appears to be a gradual decline in the proportion of women taking up cervical screening. This may also be related to several changes within the programme, in that we have moved it from being a cytology-based programme to looking for HPV. That's another virus that causes cervical cancer. So we have changed the programme to look for HPV, and then where women have that, then we are doing the cytology for them. So we're then looking at the cells. I think we are also at the stage where women who have been vaccinated are coming into the programme, and there is a degree of confusion amongst some women as to whether they need to have cervical screening if they have already been vaccinated. And the answer is that they do. So there is some concern around that as a possible reason for decline. But as I say, we are seeing gradual declines in the same way that we are seeing them nationally. And clearly there is a lot of work being done to look at why this might be the case and what we might do to address that.
We would welcome being able to share information or encourage or use being used as a channel to raise that awareness.
Thank you.
Thank you. Again, I'm sorry, Andrew, your hand seems to be up, but I presume that's now down. If there aren't any other questions, I just have one. Oh, there is. There's Claire. Go ahead.
Sorry, thank you, Chair. I was just going to respond to the question around inequalities that was raised a couple of questions ago. Just sorry, my name is Claire Barry. I'm Senior Delivery Manager for Screening and Early Diagnosis at our Partners Cancer Alliance. We cover both North and South West London. So just in terms of some of the interventions, and these are contained in the papers, but I just would want to offer the board assurance that reducing inequalities and reducing variation are at the very heart of all of the interventions that we're supporting. Not just in the recovery phase from COVID, but over the next number of years. So we have a series of initiatives that are focusing on both practices and screening centres that traditionally have the lowest uptake, and we know that there is a considerable overlap between those areas of multiple disadvantage and also areas where there are large populations of Black and South Asian and minority ethnic communities. Very happy to provide more details subsequently, but just to offer assurance that that is very much at the core of what we are doing at the moment and in the future.
Thank you. I suppose just one question from me, and I'm sorry for sounding so much like a broken record, but I'm presuming, again, we're taking eligible patient number and percentages based on the well-known sort of the WISIC data that we were talking about earlier. Is that correct, or are we doing it through a different method?
No, that's the way that we're doing it. I mean, and we've had some conversations recently with our colleagues in the CCG about understanding that data and validating that data. I know that there have been some queries, particularly in Westminster and Kensington and Chelsea, about patients who are maybe historical or transient or accessing international healthcare or private healthcare. So, but we can only work with the eligible patient population, and that's how we do our calculations.
Thank you. Yes, I think we obviously don't like being ranked last and second last on anything. But if we're not being helped to that position simply because so many residents have registered but no longer exist, I think it's probably worth taking all of these figures with a little bit of a pinch of salt until we know we're actually dealing with the correct eligible cohorts and numbers. Do we have any other questions on this item at all? Doesn't seem to be. So I just say thank you then for this. This is obviously a very important topic that I'm sure will rise up the order of the public interest over the next few months. And so I would also welcome seeing an update on this down the line. So thank you very much.
Thank you.
If we could, thank you. If we could then move on to item 10, which is the Children's Annual Safeguarding Report. And I'm inviting Emma Biskupski, apologies, I've got a complicated name, so I have some leniency. If you could please present your paper. Thank you.
Hi, I'm not Emma, I'm Angela Flarhive, so I'm the Head of Safeguarding Children's Services by Borough. Emma should be with us, but unfortunately I think our slot was 5:45. Okay, I'm here. Brilliant. I'm here. Brilliant, thank you, Emma. Do you want to introduce yourself?
Yeah, so I'm Emma Biskupski and I manage the Local Safeguarding Children Partnership across now the 2 boroughs of Kensington and Westminster, and we have had a friendly separation from our former.
Yasmin, I've got a short presentation. Can I share it? Is that okay?
Yes, that should be fine.
Brilliant, thank you. Let me just close that. Emma, do you have it to hand? Sorry, mine's playing up.
I do. Whether or not my internet will allow me to share it, hold on.
Sorry, technical issues. I apologise for this. Let's see.
Emma, can I suggest that you turn off your video? It will help with the bandwidth.
So before you in your papers you would have received a copy of the annual report for the Local Safeguarding Children's Partnership, covering the 3 boroughs. So it covered a rather strange period you may be aware of. Not just coming up now, brilliant. Of September 2019 to September 2020, and that was because it was defined by the Department of Education, because it was 1 year on from the formation of the local safeguarding partnerships from what was previously the boards, and that was following the Alan Wood report. Can everyone see the presentation?
We could, Angela, but it's disappeared. Oh, there we go.
Oh, brilliant.
It disappeared off.
I think it's up now again. Excellent, thank you. So we have those of you who may know, many of you may have already seen a presentation of sorts about this report. This is the first report of the partnership, which covered in that time Kensington, Chelsea, Westminster and Hammersmith. It was formed at that time, evolved out the old board, and this covers the first year in operation. Now, all partnerships were required by the Department of Education to review their working arrangements in that first year to see how effective we had been. And we commissioned an independent reviewer to do that, and that fed into now what is the formation of the decisions around a bi-borough partnership. But in the year that we were looking at, we looked at the safeguarding numbers, and this is quite I suppose this year previous in the terms of the numbers and referrals. We saw in Kensington, Chelsea for children's services, we saw 2,593 referrals in that year and 2,012 referrals in Westminster. I'd like to just point out there is an anomaly there, because actually the number in Kensington Chelsea reflects all contacts and referrals, whereas in Westminster, and this is really a systems issue, in Westminster we count the formal referrals. Now all that's going to be changed, and our systems are running from the 1st of April to report on that much more exactly for you. But in terms of numbers, what we did see that the police were our major contributors in terms of referral sources, and followed by education and health colleagues. I think what will be quite interesting now in the year of the pandemic to look back is that police would even be more so a larger proportion of that, because they're one of the key agencies, sometimes the only agencies having eyes on children during the lockdown. And the most common age in terms of our involvement with families is 10 to 15-year-olds. It's also the most common age cohort for those children supported through a child protection plan. And I think that's because at that age, there's a lot of change for young people. adolescence comes into play, families have to adjust to changing needs of their children, and also there's transition into secondary schools and the greater vulnerability that our children face as they have greater freedoms and wider networks. So during the pandemic, when we looked at safeguarding, what we have since looked back, really, since March 2020, was lower referral rates than anticipated. And this was the unintended, I suppose, impact of the schools being closed, no eyes on children. And what we as a partnership were very worried about was the concern around, hidden harm. And there was also concern around delayed attendance for medical care. So parents were reluctant to take their children to hospital settings, contact GPs. And I suppose at the beginning of the pandemic, there was a lot of scare out there, and rightly so. So in terms of looking at our responses, we delivered upon devised multi-agency guidance. Oh, I don't know where the presentation has gone to, sorry. We looked at multi-agency guidance development. We'd coordinated fortnightly extraordinary meetings of the lead partners to really tackle some of those gritty issues and really to be effective, a fast turnaround in addressing those. We utilised online platforms to increase our responsiveness, and actually we got greater contributions to things like strategy meetings, protect children, multi-agency meetings. So there are some great benefits that we are taking forward in our recovery. To look at, to address the issues about no eyes on children, we launched a child abuse campaign over 3 stages and ran that counter to alongside our domestic abuse campaigns as well. And during all of that, we continued to innovate practice across the partnership and utilise a lot what I spoke about in terms of online partnerships. Sorry, it's stuck on me. So Emma, could you just take I'll just go through. Emma, would you mind to speak to this slide? And this is our last slide, you'll be glad to hear, and then we're open for questions. Emma?
Sorry, I did the fatal error of talking and not unmuting myself. So the annual report there is for the arrangement from September to September of last year, and we are now in a new safeguarding partnership that's by borough, so just RBKC and Westminster. And we've appointed a new independent chair who you will already know, who is Aileen Buckton, who is already the chair of the Safeguarding Adults Executive. So we're really hopeful that will help us to join up some of our processes across both parts and help with some of the priority work that we've identified. So when we spoke with the 3 safeguarding partners who are responsible for leading the new arrangements, and so that is the CCG, the police and the local authority, we consulted with partners, but we took the lead in identifying some of these key areas that we want to continue work on. So the first priority comes as no surprise, but that's really about how can we ensure the recovery from the COVID-19 pandemic. And we want to have a focus there on mental health and well-being for our children and young people, as well as for their parents and carers. We also want to look at the issue of transitional safeguarding. Now, this is something that we started to work on last year, and we did a joint event between the two, the LSCP as it was, and the Safeguarding Adults partnerships. And we want to continue that work going forward, because we know that young people don't suddenly stop being vulnerable the day they turn 18. And there may be a need for us to think about how can we effectively safeguard them as they make that transition from childhood to adulthood. And so we need to work with a range of partners across the network to ensure that that works well. Other priorities around maintaining safer communities allow us to focus on some of the issues that we're already doing some work on in terms of serious youth violence and child exploitation, both sexual and criminal, but also in allowing us to tackle and look at issues that are emerging, such as the response to the Invited website, which is where a lot of young people testimonies about their experience of sexual harassment and violence, and that's affected a great many number of our young people across country, really. So it requires an approach and some work with our education partners, particularly to see how we can tackle that. And our fourth priority is a carryover priority from our last arrangement, and that is about reducing the harm of domestic abuse and coercive control. We know that the harm is enormous and continues to be a big feature of many of the cases that are referred into children's social care every year. So there is more work for us to do around that, and we are working with colleagues in the police, for example, around Operation Enclare. Schools will be notified by the police if there has been a domestic abuse incident of some sort. Previously, the schools will be notified the next day so that they can provide that pastoral support and ongoing support to children. We're doing some work with children's social care about upskilling their social workers in being able to better respond to and partner with the non-abusing parents in these situations and hold the perpetrators to account for their behaviour and the impact that has on their children. So we're doing a range of things there to try and help improve our responses to domestic abuse as a whole, and that involves also joint work with our Violence Against Women and Girls partnership that also spans the two boroughs. So that's a very brief overview of some of the key priority areas that we're going to be working on, and we are developing 3 new subgroups for the partnership. We have to have a case review subgroup because we still have a duty to report serious incidents and devise and publish practice reviews when they are needed. We're also going to have a best practice and development subgroup, which will be around audits and learning and development and training issues, and a new engagement and accountability subgroup, which will allow us to cascade key safeguarding messages to voluntary sector partners, wider partners, children and young people themselves, but also to provide a mechanism and a bridge for us to hear from the wider community about what their safeguarding needs are. So allow us to do a bit of a you said, we did, and share messages up and down the network. So that's it. Don't know if anyone has any questions.
Thank you. Yes, we've had one in the chat, which I'll read out for YouTube, which is, where will local children/patients be treated for residential mental health problems? I don't know if that's one for you guys to answer or for somebody else.
We can. I think there's probably colleagues in health who are much better informed, but of course we have our local children and adolescent mental health services run by our colleagues in CNWL, who offer a wraparound service and working clear partnership with us to meet the needs of children who are known to children's services. We also have a systemic clinician service within children's services, which we can meet the needs of children who we are working with, to think in a more rounded way about how we engage with the child and their family. And there are a number of mental health services that we promote, like Couth online, for young people to access themselves, plus a number of other activities. But I don't know if actually one of our mental health colleagues could pop in to answer more broadly if they're aware.
Does anybody want to take that up? Feel free to jump in if you do. Otherwise, I'll wait to see any other hands going up, which I'm also not seeing. So it will be the final call for question. Oh, somebody's just messaged in the chat. But yeah, a follow-up saying the number of beds for mental health have been reduced, which I suppose is more of a comment than a question.
And I think yes, that is yes, from Health Watch. Yes, I agree that there continues to be some challenges around meeting the needs of our most vulnerable children and young people who require residential. But there are joint packages of care in place, arrangements with our health colleagues to meet those needs. But it still is complex and challenging. I do agree.
Thank you. And I see Councillor Rendell's got his hand up.
Just more of a comment, Jem, that I just want to thank Angela and Emma and everyone else who put this report together. I think it's excellent reflection of what we do at RBKC and Westminster as well, and the good and outstanding services we provide. So I just want to personally thank them for all the brilliant work they've done.
Thank you, Councillor.
Thank you.
Excellent. And if there's no other questions, then I will thank you both as well for presenting the paper, and we will move on to item 11, which is AOB. I've had one request for AOB already from Chanel Arcott, so if we could take that first, and then if there's any other, we can take them afterwards. So go ahead, Chanel.
Chair, thank you. This is about the 2021 CCG assessment review request. As part of the Health and Social Care Act 2012, NHS England has a duty to consult with the Health and Wellbeing boards on the contribution, on their contribution to the delivery and any joint health and wellbeing strategy. To fulfil this statutory responsibility, NHS England has circulated a consultation questionnaire designed to assess the effectiveness of the CCG's working relationship with the statutory bodies within the local system. So I'd like to inform the board members that we will be sharing this consultation questionnaire with them soon. As always, the deadlines are quite tight, but you will get a date for the return date to us. So this is just an information that they will get a consultation questionnaire to respond. Thank you.
Okay, thank you very much. Do we have any other AOB on the items anybody wants to raise whilst we're all together? Hopefully for the last time virtually. No. Okay, well then we're a little bit ahead of schedule, which I'm sure, given how busy everybody is, nobody will mind. Oh, hang on, I spoke too soon. Oh, they're just thanking you, Chanel. Olivia's thanking you in the chat, so there we go. Yes, so we're a little bit ahead of time, so I'll let you all get back to your busy schedules, and thank you all for attending today's Health and Wellbeing Board, and we look forward to the next one, which I don't have the date for, but I'm sure will be shared soon. So thank you very much and have a good evening. Thank you.
Thank you, everybody.